I want to welcome everybody to the October edition of the Community Paramedicine Insights Forum, presented to you by the National Association of State EMS Officials, the National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research in EMS. This month, we are pleased to share with you all a session on a new means, a new platform that will help to enable community paramedicine services, or promises to enable community paramedicine services by bringing all of the partners in a community that a community paramedic might need at any given moment to afford their patient a social service, a medical service, or something of that sort. We are going to be hearing from Dr. Rick Piankowski, who is an emergency physician. He's also the CEO of Julota, which is the platform that we are going to be discussing today. With him, we're also going to be hearing from a couple of systems that are actually using Julota in their community paramedicine services, and we're going to hear about how those applications work and what they do, what they enable. We're going to be hearing from Andres Mercado of Santa Fe, the Santa Fe, New Mexico system, and we're going to be hearing from Julie Keys of Colorado Springs. We're also going to be hearing in absentia from Dr. Stein Bronsky, who's the medical director there. And they're all going to discuss how this platform fits in. So with no further ado, and hopefully no more technological difficulties in front of us, and I also want to greatly thank Luke Myers and now Pete Carlson, who are working with Mayo's, with Mayo, along with Gary Wingrove, and who are actually sitting in for Gary today on the controls. And thank them for putting up with all of us and making the system work. So that said, let me turn this over to Dr. Rick Piankowski. Rick?
Well, thanks, Kevin. Thanks for inviting us. As Kevin mentioned, I've been an ER doctor for over 30 years and got a master's degree in computer science somewhere along the way, and I've been very interested in connecting communities and improving people's health in general. And so what I wanted to do is turn this over to Joshua. Joshua Cast has been intimately involved with implementing Julota in many different MIHCP settings throughout around the Seattle area. And he'll lead off and give us an overview of Julota and basically what we're talking about. Julota.
Great. Thank you very much.
Joshua.
Thank you very much, Rick. Appreciate that. And thank you, everybody, for joining the call today. So Julota, what does Julota stand for? Let's start there. First, Just Love on Them Always is the acronyms that Julota actually builds out. And that's really kind of the backbone of the infrastructure and why we built the system. We realized that there's a lot of need in our communities, and we have some fantastic individuals with our EMS teams that are out there working with these individuals, and the sacrifices they lay down on a daily basis is something very impactful and appropriate. So within that, we decided to build a platform that would come alongside our EMS teams. We wanted to have something that can change lives by the way EMS connects patients to resources. That was our mission here at Julota, and that's what we did, and that's what we built to deliver. So within that, we believe here at Julota the community is critical to this type of program, and we put the majority of our monies there. So allowing different organizations within a community to communicate with other organizations within a community so EMS can get their job done. What do I mean by that? For example, the way we simplify the way that EMS connects patients to resources, we actually are a HIPAA compliant as well as CFR 42 Part 2 compliant for mental behavioral health and CJIS compliant for the criminal justice system platform. which means any and every organization within a community can now communicate with any and every other organization within a community, allowing now a hospital to collaborate with a food bank, to collaborate with a rescue mission, to collaborate with a mental behavioral health clinic, so on and so forth, and work together around a patient. So in the past, there was a lot of difficulty in doing secure emails, putting phone calls in, faxes, this, that, the other, to try to maintain compliances, which with our research we realized wasn't happening. A lot of people were sending PHI and PII information through the internet via email, unsecured. And so we bring all that together through Julota, and we create a secure environment for all of that to happen without replacing any software. So how do we allow EMS to, again, change lives? Referrals are now made quickly without phone call or paperwork. Something a navigator has told me, multiple navigators actually that I've spoken with, they've come to me and said, Joshua, anytime I have to pick up the phone to communicate with a resource organization out in my community, take 2 hours out of my day automatically, just for trying to play phone tag, trying to find the right resource organization that has a schedule that'll fit, so on and so forth. We at Julota eliminate that, and we eliminate any paperwork that needs to go out. So we keep EMS helping patients, and that's our goal. So within that, we do work as well as a standalone system, or we integrate with EPCR. And the reason that that's important with the EPCR integration is now our fire teams that are out there, they can literally click one button and refer patients into the MIH program. Julota will suck down all the information from that incident. We'll also go back and look for previous incident information and pull that information in as well. And that's kind of how we build this system, and that's kind of how we move it forward to give the MIH teams a holistic view of all encounters that have been happening with that individual. So that's something that we really, really enjoy doing. So we also we integrate very well, not only with those EPCRs, but also EHRs and health information exchanges. And the reason that we do that, we've seen so many times with our EMS teams, they'll be able to intake an individual into their program, and then they're just sitting there duplicating information, looking at one screen, trying to type into the next screen to make things work for them. That sounds like a terrible idea to us. So we save our EMS teams time by not having to do that, so they can be out in the field doing what they do best, and we just integrate with all of these different platforms, which allows information now to flow through multiple systems. We remove silos, remove barriers, and those types of things can happen. In addition, any additional 911 or ED visits that come down the pike after the individual is enrolled in the MIH program, we're going to go ahead and provide those updates to the EMS teams so they intimately know where their patients are at any and all times, and they can move things forward. So that's just kind of a quick snapshot, a little bit about us and who we are and kind of what we do and what we bring to the table here at Julota. So I will now pass this over. I think Juliet is going to be up next. Is that right, Rick?
If we can see if they'll advance the slide for us. Oh, yeah, so it is me. So my name is Julia Keys. I'm a lieutenant with the Colorado Springs Fire Department, and we started our, what we call our CARES program, basically surrounded around super utilizers or high utilizers of the ED and 911 system back in 2012. At that time, we were really on paper records. Our current EPCR that we use for the fire department is an internal homegrown program that we didn't have any way to incorporate what we were trying to do in our care side into that existing system. So we were fortunate to be able to work with Dr. Pinkowski and his team to kind of come up with a solution for us that would be kind of standalone, because we weren't able to integrate into our current system. And I just want to champion what Josh said. So early on with these paper records and having to make all of these phone calls, on top of that, we were doing all of our data collecting manually through an Excel spreadsheet, later trying to morph it into an Access spreadsheet, and we were really struggling. And so with bringing Julota on board, not only were we able to save the hours that it was taking our navigators to make phone calls, but we basically replaced or were able to resource the person that was doing all of our data entry. So it basically gave us almost 2 full-time bodies back, the one that was happening at the time we were taking for navigation on phone calls and the other on that data piece. I would say now, fast forwarding to 2018, we now have almost all of our partners on Julota. That includes our behavioral health organization, both hospital systems, our jail system, our CJC system is working with us, and it's been, changing basically the course of how and our workflow of how we are doing our stuff, and actually looking into the future with some of the things that we want to do around tiered response. It's going to be able to allow us now to talk more meaningfully with some of our primary care providers and some of those other specialty services that are separate from our hospital systems. That's me in a nutshell. If you want to move to the next slide, there you go, Andreas. Teed you up.
Hi, good afternoon. My name is Andres Mercado. I'm the Mobile Integrated Health Officer for the City of Santa Fe Fire Department. Santa Fe is a single-tier EMS-based fire department. We have a population of about 100,000 people. And in 1 year, 0.3% of our census population made up about 18% of our 911 calls. It's probably very similar to many of your municipalities or jurisdictions. In 2016, we started outreach to this population. The goal was to really link episodic care into longitudinal stories to better understand the issues that these folks were facing and to provide more efficient and more effective services. Next slide, please. I'm sorry. No, this slide is fine. So our high utilizer program is called Connect. It operates on a quarter system. We enroll about 20 individuals per quarter. Services are delivered by a team of 2 medics, 1 EMT, 1 social worker, 1 pharmacist, and 1 physician. And the lead for each one of those teams, the one that's actually making the direct patient contact on a routine basis, are the EMTs and paramedics. And it's essentially intensive case management. We started, like Colorado Springs, with paper documentation, and that came with all the difficulties which typically accompany paper. So inability to share files in real time, the risk of losing documents, the risk of exposing PHI, the difficulty of performing any sort of analytics, and the horrible process of double entry. In 2017, we started using Julota for our Connect program, and now we use it to document our entire intervention. It's available essentially on any device, so the teams have iPads, and then they come back to the office and have desktops, so it's really agnostic to the hardware that's being used, and it's also extremely customizable. So an enrollee's entire file is in one place, so their intake, demographics, consents, progress notes, etc. And this has made life quite a bit simpler. Next slide, please. The usefulness is, as many of you can probably understand, so instead of one person having the paper file and other people that are looking to do work on that file not having it available, essentially it's open for any user to access it and modify it at the same time, and pretty easy to find instead of having to figure out whose briefcase it's in or which unit it went out in. So notifications really help us stay on track with any sort of tasks that we have set up, and those are again extremely customizable, and maybe that's one of the words that really sticks out for me with the software. So quality review allows, as I said, we have an interdisciplinary team of EMTs, physicians, pharmacists, and social worker. And one thing we want to stay on top of is this is a new emerging field for EMTs, and it's really nice to have that oversight and support and be able to use the other clinicians' time efficiently so they can really access the software and the patient records from anywhere in order to do their scheduled reviews of what's going on with each individual that's in the program. because of the 42 CFR and HIPAA compliance and the locking screens and the fact that we don't have random documents laying around and being shuffled, it really reduces our exposure as far as having any HIPAA breaches. And again, the customization of the reports. Essentially, you can pull reports off of any data element that you're entering. So that's been very useful. Next slide, please. So as part of our goal to weave our incidents into one comprehensive story, our 911 incidents into one comprehensive story, we're working on linking Julota and our Zoll RescueNet EPCR product. Julota can speak in greater detail, but it's my understanding that they're already linked to other EPCR products, and this really allows a comprehensive view of the patient record. In my opinion, the future seems to be really a dual-role 911 community paramedicine world where our 911 incidents aren't seen as disconnected events, and so being able to view all the information of all interactions from your agency in one place really, I believe, will help achieve many of the goals that mobile integrated health community paramedicine programs have. I'm ready to go to the next slide, but I'm looking at the slides, and I believe that we need to jump slide 9 and go to slide 10, 11, and 12, and then come back to 9. So this is just an example. This is a screenshot of how we document interactions through Julota. So I know it's a little hard to read, but it's a really clean format. It allows for some fields are drop downs and some fields are free text. So it allows you to really be able to lock things down so you can pull the data that you need for reports, whether it's for partners or for internal dashboards or what have you. So that's just a screenshot of what an interaction looks like, and essentially almost every field there is something that you can interact with. So you click on it and add your values. Next slide, please. This is just an exit survey. Again, sorry for the small size. It's hard to read, but at the end of every enrollment, we have specific social determinants of health that we want to keep track of, and we were able to develop some custom surveys to be able to speak to those in detail to many of our partners. And then next slide, please. This speaks to the future program. So we're, even though our main program is a high utilizer program, we also have an opiate outreach program. This is the software solution that Julota is working on developing for us, and we're hoping to maybe even start using this week. This is less based around an enrollment and is more based around more transactional interactions with folks. So, for example, the opiate outreach program, we would be, instead of enrolling someone into intensive case management for a set period of time, we would just be doing follow-up, or we are doing follow-up, harm reduction education, opiate naloxone kit distribution, et cetera. So we can capture those things in a really quick and easy and user-friendly manner. As Colorado Springs shared earlier, we also have a firefighter referral program, and we're hoping to develop some documentation for that. Right now, I mean, I guess this speaks to the usefulness. We can't even scale that program up because we can't handle the paperwork headaches that come with it. So we know that once, just from past experience with the software, that once we can get it into the system, we'll be able to scale up our ability to take on more of those. So really, sort of, this is what we're looking at as far as future programs. We do follow up for a lot of different key risks in our community. So opiate outreach, falls, individuals that firefighters have identified as needing future services. So we're very happy with the ability to have all this in one centralized location, and that is it for me. Next, we're going to hear from Dr. Steen Bronski, who's the medical director for Colorado Springs, about some more uses and the importance of Julota and Colorado Springs NIH and CP operations. Thank you.
So we have a pre-recorded session with Dr. Bronski on his perspective on Julota and the use in Colorado Springs. And so, Luke, when you're ready, you can roll that.
My name is Stein Bronski, and I'm the Chief Medical Director for Colorado Springs Fire Department and El Paso County, Colorado AMR Ambulance Service. As a medical director, I do not believe that our system is unique in the issues and problems of modern-day EMS and the way that we are operating into the future that looks very different than what our past looks like. We largely have built a system over decades that responds one way and then dispositions patients one way. And we have, like other services and entities around the country, figured out certain ways to tier a response to a type of patient and send different responses to less emergent and different responses to more emergent situations. However, what we have not been good at historically is figuring out the downstream process, which is the disposition of the patient. We all know that different patients have different needs, and an appropriate resource for an individual patient or an appropriate disposition for an individual patient may and often does look very different from one to another. We've worked pretty hard in our system over the last several years to form our version of community paramedic programs and mobile integrated health programs, all trying to meet a common goal, which is to provide the right resource to the right patient in the right time frame and the right disposition for that patient. One of the issues we ran into very early on, and I don't think that we were unique in this, is that we had no framework in which to create alternative dispositions for patients. The fundamental base of all our community paramedicine programs or mobile integrated health programs was based on the non-emergent type patient, which I believe is pretty standard around the country as these programs are being developed. But traditional EMS communication networks and disposition platforms were not going to be an effective or efficient way to move these programs forward. So several years ago, we embarked on a mission to find a IT platform or some sort of platform that would allow us to achieve our goals in dispositioning the patients and getting them the resources that they needed. And there were some platforms that claimed that they could help out with some aspects of this, but ultimately we did find out from our investigation at least that there wasn't any type of platform that was truly built to accomplish our unique circumstance goals. We were lucky enough to happenstance into a relationship with some people who understood exactly what we were trying to accomplish and had the technical expertise to accomplish these goals. And for the last few years, we have been working with the Julota team to help fill this gap and open up doors to an entire world of non-emergent as well as future emergent alternative destinations for patients that EMS encounters, period. What the Julota platform has done for us is it has created an EMS-friendly platform that any type of EMS provider can use to help input information and immediately get that information about patients to all the different types of resources within the community. We started using this as I mentioned, on a non-emergent basis with our community paramedicine programs. And we learned very quickly that if we didn't have a system like this, that we would be stuck in the old-fashioned cycle of telephone calls and using human being navigators sitting at a desk as middlemen or middle people to help navigate patients. Not that there's anything wrong with that, but in this day and age, using a technology platform that can help us navigate patients and create loop closure and assignments and connect us to all the potential stakeholders that may deal with the patient on an emergent and non-emergent basis really will help us catapult into the future of how EMS operates. So through this platform, we will be able to, in the very near future, use this in emergent access EMS situations to help navigate patients to alternative destinations besides the emergency department, such as getting an emergency appointment at a doctor's office or at an urgent care, or to provide a service that will come to the patient immediately, such as food or clothing, any other type of behavioral or mental support. And this will be something that can be done by any individual EMS operator in the field very easily and in a real-time basis. That is just something that simply does not exist that I'm aware of right now in any usable form. Simply stated, I believe that this platform helps us move from the era of working with patients that are accessing EMS for emergencies to working with the entire community that is accessing 911 for all of its healthcare and social needs. If we don't look into the future about how to build our operations and fundamental IT platforms around that premise, then it will be very difficult to move into the future that we all see coming. We've only scratched the surface of the potential for this type of networking platform, and we plan to expand this greatly into our non-emergent as well as emergent pre-hospital care environment. We simply wouldn't be able to do this without this type of network.
Rick, we'll turn this back over to you.
Okay, great. So can go through Stein's next slide or two. Go ahead, advance to the next one. And I think that's where he ended, so one more slide. So yeah, so basically, I just wanted to say that, it's a lot of, we want to advance with these changes that Stein and others are seeing and actually realizing now in EMS. And we've been looking forward to this, and we wanted to build this robust platform. So, so that we can really just easily connect the EMS to the community, because that's the general direction we're going. And we put together there are two slides here, and then we'll get to the questions and answers. But basically, it's this, that we've looked at this, and we don't think you need $700,000 in a big budget to get something going. Even just with a few people, we're looking at how we can, how agencies and communities can get going. First, find a champion. Find someone with passion. It could be an EMT, a paramedic, volunteer, someone who's passionate and is willing to go out and talk to people inside and outside the agency and get this going. Find a priority issue. What really impacts you, your organization. Pick out that one problem where you could really demonstrate something significant. Maybe it's fall risks in your community, or food insecurity, or just transportation. People don't have a ride, so maybe they don't need to call 911 all the time. So find that priority issue, and then get a list of community resources. That's the next important step. And some people kind of stumble on that. And as an ER doctor, I'm going like, you know what, guys, there's a really easy way. Next time you're in the ER, you just ask the social worker in the ER or a case manager in the ER that you need a list. And if there's not someone there, just ask the nurse in the ER, hey, do you have a contact info for a social worker or a case manager? And they'll get you one. Just ask them, and they'll be able to get you a great list of community resources, the social worker or the case manager. So on the next slide, you're obviously going to then have to talk to your agency about protocols, and does anything need to be changed the way we're doing things? That's obviously important. And then get this group together that you've contacted. Have a meeting with the community resources and yourself, and figure out, just how this process is going to work out. And then you're really ready to get going, even with just one or two people. I think you really can start small and get going. You don't need a super huge program to get this off the ground. So with the next slide, I think I'll turn this over. I just noted, we had this as an ending slide, that really this is what we're about, right? We look at the situation and say people are wasting their time, their money, their resources, and they don't communicate. And how can we bring everybody to effectively collaborate and actually get out there proactively ahead of time and identify problems and really help people? So the next slide gets us to Q&A. And so I'm going to ask Kevin to kind of run things.
Great, Rick. Thank you very much. And I want to thank all of you for your contributions to the presentation. I would ask Luke to please unmute everybody, and then we will get into the Q&A.
The conference has been unmuted.
Okay, super. I'd like to start with a quick question for Lieutenant Keys. Are you still with us?
I am. Go ahead.
Dynamite. Can you describe a patient interaction, a community paramedicine or a CARES patient interaction in the field, and what physically you're doing to, say, refer that person to one of your resources? When you have the conversation with that patient and they agree that they need, X, Y, Z, what do you then physically do? We saw some of the documents that Andre showed us. They were a little small, so it was a little hard to appreciate that. But if you could just describe how you interact with Julota to get your patient a resource.
Sure. So part of what we do when our team goes out is basically it takes about an hour and a half to do kind of a full medical and social history, so that we can fully appreciate, they have what they feel like their issue is right in the moment, but our goal really is long term to move them into a completely different healthcare stream. And so I'll tell you that in our program, we usually work with our folks pretty intensively for about 6 months. So it's, there's the quick fix kind of in that moment, but I want to understand that really our goal is not necessarily just kind of putting out the spot fires, but to really come up with a good plan to move these patients and walk alongside them. So using Julota, so when we go out and we identify some of these issues, so it could be something like transportation, and we have those systems, those resources built into our program. It's simple, real simple for our folks they put that in as an action item, and our navigators are able to then ping if they're in our system. So like I said, we work with lots of different resources within the community, and we're able to shoot them an alert through Julota, and then they get that when they're opening up their email. They'll see that they've got an action item. They can log into Julota and see that, oh gosh, this patient is a Medicaid patient that belongs to our system, and yep, we can work on getting them an appointment to their, or ride to their next appointment. So that piece of it works very, very seamlessly. I think the biggest bonus for us is not having to recreate that every time we're talking to somebody working with that patient. All of that information is in Julota. They're able to see everything that's appropriate for them to see with that patient. And then if they've completed that, then the system gives us a notification that says, hey, you know, Julie over at Aspen Point was able to get that patient in and provide them transportation for that appointment. And so it creates this feedback system for us. Instead of wondering, hey, did they actually get that done, we're getting that notification through Julota.
Okay, that's great. Thank you. Andres, would you paint it pretty much the same way?
So again, as I said, one of the nice things about Julota is that it's very customizable. So we have a slightly different use of the product. And for us, currently, we are not linked into several other organizations through Julota. We're using it more as a replacement for our paper files, and it's worked really well for that. But what it does allow us to do is keep track of in the interactions documentation. We keep track of so we document either using the DAP format or just progress notes, depending on the interaction type. And then it allows us to follow up just internally, have some sort of quality controls to understand, based on previous interactions, are appropriate referrals being made. So right now we're still, as far as referrals, we haven't optimized the use of the software. So I guess, you know, it speaks to the scalability of it. You may not have a lot of partners in your community that are ready to jump on, or some may be on board and some may not, but it's still very useful to move away from paper. At least it has been for us. So we're really using it more, again, as a documentation tool, and it allows us to, because we're documenting on the spot on the iPad, it allows us to then make sure that we hold ourselves accountable to those goals, to those referrals. We are able to follow up on whether that person was able to get transportation or not. So smaller operation than Colorado Springs, absolutely, and also just a scaled down version of that process.
Thank you. Okay, let me open it up to folks in the audience. Anybody have a question for any of our speakers?
Kevin, there's one question on the.
Can you please read that, Luke? I don't have that screen available.
Sure. How well would this interface with community health worker programs, and what is the cost for small rural facility users?
Yeah, this is Joshua here. I'll go ahead and I'll field that for Julota. Yeah, it's going to work very well with the community health worker programs. I'd like, if I could, Joan, at some point in time to get some a little bit more information about you know, what exactly you're doing. And as far as the cost is involved, that's also going to be a play based on exactly what you're doing. So just for a basic rule of thumb, we see a lot of our packages range from about $15,000 to $22,000 for kind of a basic start area. But it really depends on what type of program you're bringing together, you know, how many folks you're going to be going through and seeing, so on and so forth. So let's have a conversation around that. But yes, we are intimately built for community health worker programs.
If I can jump in, this is Andres from Santa Fe. So we are essentially working under a community health worker model. So our EMTs and paramedics, even though the clinical training that they've had comes in handy from time to time, if there is a medical issue, they're essentially following 911 protocols. We have not followed an advanced practice paramedic model or the community paramedic model. primary care extension type model. It's really our EMTs are functioning as navigators, so as community health workers. That's really what we're doing, and it's worked very well. As I mentioned, our intervention is structured around social determinants of health, which is what a community health worker would be addressing.
Great. Do you have any other questions?
Yeah, I have a quick question.
Please.
You mentioned the cost can be around like $22,000. Is that, I mean, how does that work if does each organization or entity that would like to be a part of like the collaboration in a community have to purchase it individually, or like can one entity purchase it and allow access to multiple people?
It's a fantastic question. Thank you for asking that one as well. So what happens is typically we run on a hub and spoke type of system, and in the software world, that means that one organization will purchase the software, and then it'll cascade out for the other organizations to be connected to the software platform. So the way we work here at Julota, once you purchase the platform, no matter what package you're picking up from us, you're going to be able to connect to an unlimited number of resource organizations. So you come back and tell me there are 1,000 that we need to connect to, we're going to connect to 1,000 of them. So that increases the power and the potential of your program by connecting community resources, because as I spoke at the beginning, again, that's what we believe is the most important and paramount piece to taking care of these patients is connecting community resources. So we want to make sure you're able to do that. Did that answer your question?
Yeah, and a quick follow-up question to that. Is it a one-time cost, or is there like a baseline larger cost and then like ongoing maintenance and support costs?
Another great question. Thank you also for that one. So no, there's no maintenance cost. What the fee is exactly what the fee is. It is an annual reoccurring fee. So our platform is software as a service, so we're cloud-based. That's how we don't replace any existing software that's at any of the resource organizations in the community, but allows us to actually implement and connect with all of those other resource organizations in your community without causing them any heartburn or pain from their current system that they're in, and still maintain those compliances.
Awesome. And then I have another quick question. I was curious, so one thing I saw on one of the slides that it was mentioned that either you guys do currently or are looking towards being able to connect it with Zoll. Do you guys does it currently work or like read write to image trend at all?
So I love that you're asking that question. We're actually in talks with ImageTrend. I cannot say yes or no to that answer at this time, but some of our customers who are running ImageTrend currently have brought us into conversations with ImageTrend. I can at least share with you that those conversations are going well.
Okay, yeah, I was just curious because I know they have their own community paramedicine like platform, but I wasn't sure if they would be like open to that conversation or not.
Yes. Thank you for asking. That was a really good question.
Yeah. I think those are all.
Thank you.
Well, this is Rick. One of the points about that, though, is that there are other software companies, EPCR companies, that have started their own CP application as part of their suite, but they're not a community platform. Right. They don't bring in all of the organizations throughout the whole community, and that's how we differentiate ourselves. So we don't really look to compete with them along that. We think we bring in a much needed, very, very important piece when you can bring in the other 30 or 100 or 800 organizations in your community to all work together. And that they don't do that.
This is Julie Keys. I just want to add on to that. One of the biggest benefits to that, because we did try to explore looking at some of those already existing platforms, and the biggest difference for us with Julota is although our partnering agencies still have to log into a different software, so they're maybe they work in Epic, maybe is their medical record, and if they want to send us a referral, excuse me, they're having to open that and do that in Julota. But there was no cost on their end for that. So we purchased that, but that was the win for us, getting our partners on that. And again, the benefit to us was obviously saving those staffing hours to move those people to do other things. But before, we would take fax referrals from the hospitals if they wanted to refer a super utilizer. Now that those social workers log into Julota, for those firefighters out there, I'll tell you, it's firefighter proof, right? So if I can get my driver engineers to figure out how to log on, just about anybody can. And so they're putting those things in, and that information's coming directly to us into our own software. So we're not having to re-enter all of that data that we're getting from the hospital. It's automatically fed in. And then getting those feeds from the hospital through our health exchange at the state level is invaluable as well. So you can get notification as soon as a patient enters into the ED. That can be sent directly into your software. So again, I think that connectivity is a lot different than some of those kind of standard community paramedic software programs that are out there.
I have one more additional question.
Sorry, go ahead.
Oh, sorry. Thank you for your comment. It made me think of another additional question. Do you guys interface at all, or are you in communication with Collective Medical Technologies for their EDDI pre-managed platform, or do you guys have an ability to pull in like emergency department utilization or like inpatient admission information through like the ADT feed, or do you have, does anything like that occur?
Another great question. Thank you for that one. So with the EDDI system owned by Collective Medical, we do have some integrations right now in the state of Washington that are actually happening with some of our cities. Currently, what we're doing in place there is we're actually sending them information. Once the MIH team brings a new individual on board, we send them the information for that individual. So their emergency department and information exchange will then kick back all the updates for those individuals. What we have not received back from them is we'd like to have that information flow automatically into Julota. They have not finished up that integration piece yet, but it still allows our teams to be able to continually get updates. That being said, for the folks who don't have access to Collective Medical here on the call, there's a lot of health information exchanges that are out there, and some of them are more widely adopted than others. And also, of course, the hospital systems connecting into their EHRs. Those are other pieces that we do play in and spaces that we step into, and those do provide some of those updates, as well as connecting with fire and their EPCR system, especially if it's connected with dispatch. So a great question, and yes, we are working with CMT.
Thank you.
Any other questions? I want to thank you for asking all those questions, because if you hadn't, we might not have had any. Anybody else have any questions?
Hey, Kevin, this is Scott Winston from Virginia.
Yes, Scott.
I have a question about the data analytics and how that, who performs that, and at what level it can be, what level it produces information. Does it have to be run by Julota, or can the local user run analytics to look at the data that they're collecting?
I'll jump in real quick, and then Joshua, I'm sure you can, and Rick, you can answer more fully, but I'll just explain to you how we're doing it in Colorado Springs, because that's the piece that Andrea spoke to around that kind of adaptability to what your needs are. For us, we wanted complete access to all of our data, so that Julota provides that to us. We're fortunate enough to have a senior analyst that we do a data dump of all the information that's in Julota, and then we are able to use that data however we want. Before we got our senior analysts, they created reports for us. So we gave them kind of the parameters of what we needed, and then those reports were built for us. So there's functionality to do all of that. But for us, we like being able to kind of dig around and play in our own data. So that's all of that is accessible to us. And then Josh, I'll kick it over to you or to Dr. Pinkowski.
No, thank you for that, Jules, very much. Yes, to answer your question, Scott, I believe, So we can do it in any different flavor that you would like to have that information, as Jules was just expounding upon there. We can actually just do a full data dump if you'd like us to do that and get that information over to your analytics team. We also have a very robust analytic engine that we can turn on based on what information you're looking for. So we have a belief system here at Julota. We believe that a lot of these programs are currently looked at for grant money from a federal and a state level. We also believe that these programs are going to be looked at for some grant monies in the future in 2019, 2020, and 2021, so on and so forth. As we're doing that, something we don't know right now is what type of information they're going to need for those grants. So we position ourselves as Julota by collecting literally everything of data that we can collect from your system to prepare ourselves and future-proof ourselves. So when a grant becomes available, you know, let's pretend 2020, something federal becomes available, we can run that report based on what information that you're needing and backdate that report as we need to do it to deliver the deliverables that you need to go ahead and win and be awarded that type of grant monies. So yes, we can run it literally womb to tomb any way that you're looking at it. Your team can run it, or we can run it, and we've got some very nice analytics behind there. We can talk more about that offline if you would like.
Well, and I just wanted to add one thing too, that we, and it sort of piggybacks on what Josh was just saying, that we're a point-in-time system, so that you can go back and look at the data, you know, from, you know, it doesn't just have to be a current period, a current quarter, whatever. You can set the time frame from, you know, October 22nd of 17 to December 31st of 17, and it will look at the data and analyze it just at that period as it was at that period, even though maybe their person's insurance has changed since then. So we're a point-in-time system, which is useful. And also, you know, you kind of hinted at the resolution of data in your question, and actually in my master's work, that was one of the things that I was particularly interested in as a physician, was the fine granularity of the data, and that's how we built Julota. So the data elements are as detailed as you can imagine. I mean, you know, if you wanted to set it up and only look at, you know, people's diastolic blood pressure only, you know, that data element is separate from anything else, and we can look at any fine element of data that needs to be looked at. I don't want to go on and on about that, but that's the resolution of data is very important.
That answer your question, Scott?
Yes, it did. Thank you very much.
Great. Are there other questions out there? Okay, hearing none. Rick, do you have any last, or any of the speakers, any last words of wisdom?
Well, I would do nothing special. I want to say thank you for inviting us, and thank everyone for taking the time to kind of hear what we're about. And we're looking. We see EMS is just vitally important. There are a lot of different ways, actually, with this kind of network platform that we could go, but we see EMS as just being a critical, vital area. It has its fingers out into the community everywhere, and if you really want to make an impact on a population's health and the community, I can't think of a better way to do it than to go at it from an EMS kind of approach. And so we're excited to be in this space, and this is what we live for. Thank you very much for inviting us.
We thank you for being with us today and bringing such a robust team, Mr. Cast, Drs. Bronsky and yourself, Dr. Pinsowski, Mr. Mercado, and Lieutenant Keys. It's been a very enlightening session, and again, I want to thank you. This will be put up on the cpif.communityparamedic.org page that you all registered on within the next 2 or 3 days as an archived show. If you want to have somebody else take a look at it, or you want to look at it again, that will be available to you there. I want to thank all of the speakers again, and as well as Luke Myers, and now a new addition to the cast at Mayo, Peter Carlson, for sitting in for my usual partner in crime, Gary Wingrove. But I thank Mayo for their contribution to this, and as well as the National Organization of State Offices of Rural Health and National Association of State EMS Officials and the Center for Leadership, Innovation, and Research in EMS. We will have another program on November 19th. It's always the third Monday of the month at 3 p.m. Eastern Time, and I look forward to seeing you all then. Have a good rest of the week.